Okay, good evening, everybody, and welcome to the latest study club meeting. Today, we've got the privilege of listening to Dr. Komal Majumdar. Unfortunately, Howard can't be here today, but he said I must mention that Komal was one of the first students that he taught in India, and in the last few years, she's become a rising star. And looking at the number of participants we already have waiting, I think there's keen interest in the topic of discussion that we have tonight. So Komal, thank you for taking the time to come and talk to us. We can't wait to hear what you have to say, and we look forward to it. Over to you.
Thank you so much. Thank you so much for inviting me. I really was very, very happy and honored when Dr. Harvey Gluckman invited me to speak for his study club. I have learned a lot from him, and he has been a major influence in the way that I practice, the way that I work. So I'm honored.
Thanks. I think you can share your screen. Is everybody getting the sound? Seems fine on my side. I think let's try it out. Come on.
All right. So I think somebody said yes. So
okay.
We can just go ahead and start the presentation. Okay, so you all will have to excuse me a bit. This is post-COVID, the first time that I'm doing a webinar, and I'm so glad that COVID got over, and really not a big fan of webinars, primarily because I'm extremely bad with trying to play around. The last time when I was doing webinars, it was kind of easy because I had my son to help me. How kids are a little more tech savvy. And since he's missing in action now, I'm trying to figure out myself. So please pardon me, all of you who have come here. First of all, a big thank you to everyone. We announced this webinar quite late. I gave the link pretty late to everyone. So it's really heartening to see all of you. And let me tell you that it is 10 p.m. in the night here in India. So although it's 6:30 there, it's 10 p.m. So you can see the enthusiasm. I'm so happy that whenever we get a chance to learn, we are always there at it, whether it's 10 o'clock or 12 o'clock. So thank you. I'm sorry.
Please just mute your microphones. Thank you, Komal.
Yeah, shall I continue?
Yes, please.
All right, so a big thank you to everyone again, and a big thank you to Implant and Aesthetic Academy and the Study Club. Thank you, Laurie, for being so kind and being so patient with me. All these mails that we have exchanged, and you have been more than accommodating. Thank you again for all that help that you have given me. So now let's go ahead and talk about the topic for today, and that is remote anchorage solutions. Now, what are basically remote anchorage solution implants? Let's come directly to the topic there. And remote anchorage implant solutions basically are those implants for those patients who have such severe atrophy that their conventional implants is not possible for them. And what are these implants really? These implants are your transnasal, trans-sinus, zygomatic, and pterygoid implants. And also one more implant that I can include in this is the nasopalatine implant. So when you have a patient who has got severe atrophy, this is the kind of implants that you really want to go for these patients. Now, how are we going to go about this for the next 1 hour that we have? We are going to go about this in 6 parts. In the first part, I'm going to talk about what really are remote anchorage implant solutions. There is something wrong. Yeah, so we are going to go about in 6 parts. In the first part, we talk about why do we really need remote anchorage implants. We talk about the different types of the remote anchorage implants. This surgery is a little more tricky than your conventional implants. So anatomy, understanding the anatomy becomes extremely important. We talk about the surgical and the prosthetics in remote anchorage implants. I don't think that any discussion can be ever completed without talking about complications that can happen. And finally, we will conclude this webinar with some take-home points. So let's start with the first part. Why do we really need to go for remote anchorage implants? Now, I'm sure that all of you will relate to this scenario, the clinical scenario that I want to talk about. Now, this is a kind of clinical scenario which is very, very rare, especially in a country like India that we practice. There is usually a lot of atrophy. And it is very rare that this kind of patient walks into a practice with so much of bone. So when this patient comes in with so much of abundant bone which is present and he wants a fixed replacement, really things are so much easy for us. And I'm sure everybody would agree. So here we went ahead and just simply placed multiple implants, axial implants. I got good primary stability. Since I was looking out for immediate loading, a little more number of implants have been placed to increase the composite torque, the overall torque value of all the implants. Immediate provisional was given to the patient. The patient came back after 4 months. The healing was perfect. We went ahead, we gave him customized abutments, and we went for cemented restoration. This was the final prosthesis in the lateral and maximum intercuspation. And you can see beautiful fitting prosthesis, good AP spread, all the implants have integrated. This is very rare. The routine, what we will get is some amount of atrophy. So when we see that as the patient remains atrophic for a really little more longer period of time, they come with an atrophy that mimics something like this. So we had this patient here, Michael, who came to our practice with the initial situation looking like this. Now, this is a classic all-on-4 situation where there is some amount of pneumatization of the sinus. And this is what his pre-op was there. He had come with some teeth remaining. We went ahead, extracted those, placed our all-on-4 tilted implant protocol, placed our multi-unit abutments, and very, very straightforward case, giving immediate temporaries to the patient. Once the implants integrated, we changed it to zirconia, titanium with zirconia restoration. This is in maximum intercuspation, and again, a very, very straightforward, something which is now very routinely done in our clinic and our practice, just not in our clinic, but across the clinics in India that this is practiced. And if the patient comes with some amount of mandibular atrophy. So mandible is really not that tricky because even if the patient is severely atrophic, there is usually some amount of bone that is present. So for example, this patient here, he's a 55-year-old man. He has a denture, but he's not very happy with his lower denture. So we go ahead, we examine him. We look at his ridge, it's well healed. Classic again situation where there is posterior atrophy. The nerve is pretty close to the crest. And again, anybody who has been doing implants for a long period of time would just look at this case and say, okay, this is a simple all-on-4 case for the lower. We go ahead and place the implants. We get high stability, no big drama here really. Implants heal, we give immediate temporization. After the implants heal, now we have gradually gone more towards the digital. So we're taking the digital impressions, we're taking the bite, and within a period of 2 or 3 sittings, really, that this protocols can be completed. And in our country now, there are labs who can really deliver good quality prosthesis and in a very, very limited period, very quickly. So this is the patient in maximum intercuspation. And if you have some luck, so I'm showing various clinical situations. If you're in some luck, a patient would walk in something like this. So there is some minor atrophy. For example, this patient here, she came in. There is no relevant medical history. She has been edentulous for a very long period of time. There is an atrophic maxilla. You can see that the bite is collapsed. And well, apparently she has a low smile line here. And when the patients have money, they usually come with some problems or the other. So here she had the money, but there was a bloody impacted canine that was situated right there, which prevented us from placing the implant. So these are tricky situations, and I'm sure that everybody can relate to this and how frustrating it can be. So we went ahead, we opened up the flap, I placed the implants, tried to get good AP spread. I retained some teeth to give some kind of temporary to the patient. This was the defect that was there, minor defect, can be easily done with some minor grafting procedure. Placed my membrane, closed it, and kept 2 teeth, as I said, for giving the patient a fixed restoration. I do not like to give the patient any kind of denture that will cause unnecessary loads on the implants. And of course, the implants healed. We did the second stage surgery. We replaced the healing collars with multi-unit abutments. And we did the digital scan, we did the jig trial, the jaw relation, the teeth setting. Now we're trying to get the bite corrected. And then we went ahead with the lab steps. The lab technician designed it in the CAD software. We did a PMMA trial. We checked the occlusion. Some access holes were buccal. But considering the kind of atrophy she had, I think we did a fairly good job. But this is not a problem at all. The fitting was good because it was a milled prosthesis. We went ahead with PFM and some amount of, since the access hole were buccal, we gave a veneer separate veneer on those areas. So we went ahead, did the etching of the veneer. We washed it, we dried it, we put some layer of bond. And once the access holes were sealed, we went ahead and cemented the veneer. This was post-cementation. This is the maximum intercuspation. You can see the occlusal aspect in excursions. This is the final smile. So this was before, this was after. You can see the difference in this patient. Beautiful blending with the soft tissues, beautiful textures. The technician was really talented in whatever he did. This was the post-op OPG, the final smile, and really a happy patient at the end of it. Now, this is not, which is very common. This is something which we do not see every day. Chances are that you are going to get patients who have atrophy in the horizontal dimension, both in the anterior and the posterior. And I remember this patient almost more than a decade ago. This patient came to me and I had to refuse this patient. I could not do anything for this patient. I told him that there is no bone and you require some extensive grafting, so we really cannot do much. And if your luck is even worse, you will have a patient who has the money but will have also vertical and horizontal atrophy. Now, what is the solution for this? Now, the problem is when these patients come to you and they are ready to go for treatment, for expensive treatments, and you refuse such patients, you really start to feel like a big time loser because you want to do the treatment, but you don't know what the solution is. Well, is this the solution? I've learned this from Dr. Harvey Gluckman, and it's a beautiful procedure. And I remember doing this case, and I'm going to show you this case. This is a full arch Khoury technique that I did. So here this patient walks in, she's got severe atrophy. You can see the vertical height is present, but there is some amount of horizontal deficiency. This is knife edge ridged. We open up. I harvest the graft from ramus on both the sides, stabilize it, pack it. And we did get good amount of bone after a period of 4 months. And there was good amount of bone for me to go ahead and place implants, get good AP spread, place all the implants, place my multi-end abutments, and place my prosthesis at the end of the surgery. And honestly speaking, I felt absolutely amazing. This patient looks happy right now. And I was on the top of the world because it was quite a difficult task for me. And since the patient looks happier, I'm sure you would all agree that the patient was not happy once she went back home after the surgery. I felt like God after that surgery. But we have to understand that patients really don't come for your awesome surgical skills. They come for teeth, and we have to keep that in mind because no patient in this time and age is going to accept this kind of extensive treatment, which involves a lot of grafting. The reason why they do not want this treatment is first and foremost, it's extremely aggressive for the patient. And the worst thing that you can do to this patient is not even give any kind of denture to the patient, because once you do this extensive grafting and you place a denture, all the graft is lost. So this is one of the biggest problems why I do not want to opt, how much ever I love doing this for this patient. And now the time has come that the patients do not want to, if you give this option, your patients are not going to stay with you. The patient is going to go ahead and ask for a second opinion. So so let me share with you one case. For example, this patient of mine, who had gone to some other dentist, not naming the dentist, but he had gone there. And when there are options available, when the patient is told that I'm going to give you restoration very, very early within a period of 3 days, they are going to opt, and they really don't care what kind of implants you're placing as long as they get their teeth. And quite a lot of times this works, but there are some times, like for example, in this patient, the implants failed miserably. And not only did they fail miserably, but along with it, it took away a lot of bone. So yeah, we definitely managed this case. It was quite a tough case, and we did manage to get the smile back. But this was, again, something that we don't want for our patients to go through this procedure. I mean, I want to do immediate loading too. I also want to give my patients restoration in 3 days, but I want to do it in a much more scientific manner, something which is much more acceptable, which has got, in which there are adequate literature that is published for these kind of for the implantology that I do. So that gets us to the topic, and that is the reason why, because we are going to have patients who are looking for solutions which are immediate. They want immediate teeth, they do not want to wait, and they want to eat as fast as possible. And that is where, when you have severe atrophy, so answering the question, what really is remote anchorage implants? Basically, it is a graftless solution for extremely atrophic jaws. So now, what are the different kinds of remote anchorage implants that we're talking about? So there could be your remote anchorage implants include your pterygoid implants, zygomatic, transnasal, nasopalatine, tilted implants, and trans-sinus implants. The question is, how do we decide where to go forward? Now, one of the most beautiful classification that has been given by Bedrosian is a 2D classification. He divides the maxilla into 3 zones. Zone 1 is from canine to canine, zone 2 is premolars, and zone 2 is molars. There's also a 4th zone, that is your zygoma. So if you've got adequate bone present everywhere, the case becomes straightforward, go with your axial implants. If you have bone only in zone 1 and zone 2, you're going to go for tilted implants. If you have got bone only in zone 1 and nothing in zone 2 and zone 3, you go with something called as a hybrid zygoma. That means you place your implants in the anteriors and place single implants on each zygoma. And if the patient has such severe atrophy when there is absolutely no bone present, then you offer quad zygomas, that is 2 zygoma on each side. And if you want to reduce the cantilever, you can also add in your pterygoid implants along with it. So, or in this patient, for example, we went with a combination of remote anchorage implants. So it is the choice is yours depending on what kind of atrophy you're dealing with. So then let's now talk about, since we're going to talk about all of these implants, let's really talk about the relevant anatomy. Let's start with the relevant anatomy for the zygomatic implants. Now, zygomatic implants are anchored in zygomatic bone. Now, zygomatic bone is an irregular cheek bone which has got 4 borders: the temporal border, orbital border, maxillary border, and the zygomatic border. And it is connected to 4 bones, that is your frontal bone, temporal bone, sphenoid bone, and the maxillary bone with their respective sutures. If you look at the surfaces, there are 3 surfaces that zygoma has. One is the outer or the malar surface. This is a surface where your zygomatic implant is going to be perforated and is going to come out and extrude a little bit. This is the surface which has got the zygomaticofacial foramen through which the zygomaticofacial nerve emerges. Now, what is the clinical significance of the zygomaticofacial nerves and vessels? Now, because we have to be aware of this zygomaticofacial nerve, primarily when we are doing our quad zygoma. So if we are not very careful, we might just go ahead and damage this nerve. Coming to the orbital surface, now zygoma bone forms the lateral wall of the orbit. The orbital surface of the zygomatic bone has the zygomatico-orbital foramen. Now, this is the foramen through which the zygomatic nerve passes. It has an orbital tubercle where your muscle of the eye, the lateral palpebral muscle, gets attached. Again, why is the orbital surface so important and so relevant for us? Again, when we are doing our quad zygoma, if you're not very careful, we might just go ahead and perforate this orbital surface and be inside the orbit. This is something that you really do not want in your patients. Coming to the temporal surface is a surface that is posteriorly and medially present. The temporal surface has a zygomaticofacial, it has the zygomaticotemporal foramen through which again the same nerve passes. Now, the relevance of this the temporal surface is that it has close relation to the temporal and the infratemporal fossa. Now, what is there in these fossae? These fossae contain some of the very, very important relevant anatomical landmarks. The temporal fossa, for example, contains your auriculotemporal nerve, deep temporal nerve, temporal branch of the facial nerve, and the mandibular nerve. It also contains your temporalis muscle and your middle temporal artery and vein. Below the temporal fossa is your infratemporal fossa. Now, the most relevant anatomical landmark in the infratemporal fossa is your pterygoid venous plexus. What is the relevance of understanding this? Now, the relevance really is that when you go ahead and do your drilling, once your drill goes inside the zygoma, once it perforates the sinus, it should go ahead and directly go inside the zygomatic bone. If the drill deviates, it will perforate the posterior wall of the sinus and it will go into the infratemporal fossa. And you do not want to damage those critical anatomical landmarks. What about the relevant anatomy related to pterygoid implants? Now, when you're going to place your implants, your pterygoid implant, you are going to engage this pterygomaxillary junction. This pterygomaxillary junction is made up of 3 bones, three parts. 3 bones really form your pterygoid pillar or your pterygomaxillary junction. You have the tuberosity of the maxilla, you have the pyramidal process of the palatine bone, and the pterygoid process of the sphenoid bone. If you talk about the maxillary tuberosity, we know that it is one of the softest, most poor quality bone that will be present there. It has very, very thick mucosa, and you do not get enough primary stability with your maxillary tuberosity. Now, sometimes you will see that the patient has a very bulbous maxillary tuberosity. It is coming actually below the occlusal plane. So you have to keep that in mind when you are going ahead and placing your pterygoid implants. If you're not very careful about that, you will have very less restorative space there. So there are times where you'll have to reduce the maxillary tuberosity before you place your pterygoid bone. The clinical tip that I want to give here is that when you're doing your drilling, when you start your drilling for the pterygoid implants, never start with the drill. Always start with the osteotome, because your osteotome is going to pass first through the soft bone of the maxillary tuberosity. If you take your drill, the chances are that you might deviate and not go in the right direction. And like I said before, sometimes the tuberosity can be very bulbous. You might have to reduce it before you start doing the drilling. The first bone, which is hard, and that is you're going to encounter, is your pyramidal process of the palatine bone. And then you have your pterygoid plates, or the sphenoid bone. Now, these two pterygoid plates are the medial pterygoid plate and the lateral pterygoid plate. And where they meet, that is the junction where your implant is going to be engaged. So this is your main target area. So you have to start drilling in the posterior, medial, and superior direction when you're going to go ahead and do your drilling for the pterygoid implants. Coming to the relevant anatomy for transnasal implants. Now, before we actually understand the anatomy of the nose, we have to understand the function of the nose. Now, nose basically has three functions. First is olfactory, or smell, and there is an olfactory bulb which is present. The second is nose is the area where all the paranasal sinuses come ahead and drain. And the third and the most important, of course, is the respiratory function. Now, for the respiratory function, if you look at the nose is lined by keratinized multi-layered squamous epithelium. There are some sebaceous gland, there are some sweat glands which are there, and it has microcilia which captures the inhaled foreign debris, and it humidifies the air. Now, when it wants to humidify the air, when it wants to clean the air that we are inhaling, it requires a larger surface area. So to increase the surface area, if you look at the nose, there are certain bony projections which are present, which are called as the concha. So there is a superior concha, middle concha, and inferior concha. The superior and the middle concha are the part of the ethmoidal bone, whereas the inferior concha is your separate bone altogether. And we really are interested in this inferior concha. Now, the inferior concha articulates with the ethmoid bone, the palatine bone, the lacrimal bone, and the maxillary bone. Now, we are really interested in this junction where the maxillary bone meets the inferior concha. Because when you're going to do your transnasal implants, this is the area, the anterior-most point of the confluence of the maxillary bone and inferior concha is where you're going to engage your implant. This point is called as the Z point. Okay, it is named after the person who started placing transnasal implants. So this is what is called as the Z point. This is exactly where you need to place engage your transnasal implants. Now, obviously, the nose is not just a drainage drainage for the paranasal sinuses, but it is also a drainage area for your tears. So that happens through your nasolacrimal duct. And there is a nasolacrimal drainage canal which is present, which is going to go and drain in the inferior meatus. So we need to be aware of this, because when we are placing our transnasal implant, we have to keep in mind not to block this nasolacrimal opening. Otherwise, it is going to cause complications to the patient. So what do you see? How do you analyze whether this patient is fit to go for a transnasal implant or not? So you need to see your CVCT. So the first thing that you're going to see is the prelacrimal recess, the space between your anterior wall of the sinus and the anterior border of your nasolacrimal duct is called as a prelacrimal recess. And there is something called as the bony prelacrimal window. That is the bony window which is present again from the anterior wall of the maxillary sinus to the anterior border of the nasolacrimal duct. Now, there is a classification for this bony lacrimal window given by Siemens. He says that if you have less than 3 millimeter of bone, it is a type 1. If it is 3 to 7, it is type 2. And if it is greater than 7 millimeter, it's a type 3 kind of bony lacrimal window. And he says that if you have 7 millimeter of bony lacrimal, the distance is 7 millimeter, there is very limited chance that you're going to go ahead and damage your nasolacrimal duct opening. However, what we have to understand is this length does not really matter to us. What really matters to us is the thickness at this junction. So if you want to engage an implant which has got a diameter of 2.5, the minimum thickness that you want at this area should be 3 millimeter. So even if your distance is not 7 millimeter, but you have got 3 millimeter, you can go ahead and do your nasolacrimal, you can do your transnasal implants. But if you have 7 millimeter, but your distance, if your thickness is not 3 millimeter, this patient probably is not a good candidate for placing a transnasal implants, because there is high chance of you damaging the nasolacrimal duct opening. Coming to the relevant anatomy for nasopalatine implants, when if you want to place a nasopalatine implant, obviously it has to go in the nasopalatine canal. And what is present in this nasopalatine canal is your terminal branch of internal maxillary artery and the nasopalatine nerve. More about it when I actually come to the case and we talk about how we can do these kind of surgeries. Now coming to the bulk of the presentation, and that is the surgical and prosthetics in remote anchorage implants. Let's start first with zygomatic and nasopalatine implants. What are zygomatic implants? These are extra long implants which are placed in severely atrophic jaws, where the anchorage is taken from the dense and remote zygomatic bone. The zygomatic bone is the cheekbone, which is purely cortical in nature. And once you engage your implant here, you get high primary stability. And that is why you can go ahead and load these implants immediately. Now, the zygomatic implant placement can either be done with a free hand, or you can have your special guides. For example, Norris has this e-Zygoma, which is fabricated. It's currently not really available in India for the reason being that there is not enough labs to support making these guides. And also, the problem with this guide is that it is relatively expensive. What I like to work is this guide, which is a metal milled guide, which is fabricated. This is made in India, and this can be done. And I find this extremely reliable to go ahead and place my zygomatic implants. You obviously require a specialized kit. Now, there are multiple implant systems in the world that do zygomatic implants, and whatever system you follow, you just need to pick up that particular kit. So here, since I do Norris implants for zygoma, I have a Norris kit which has got these diamond drills for tunneling, and you'll understand the relevance of this when I actually talk about the procedure. The drills obviously are going to be longer than your conventional drills. There's a depth probe, and there is an implant driver, which is handheld when you're going to place your implants. The next thing that is most important is when not to go for zygomatic implants. Whenever you opt for a case, and if you see that there's acute sinus infection, or is there any kind of maxillary pathology or zygomatic pathology, or obviously malignancy, zygomatic implants is not indicated. One of the other things that is not talked here is mouth opening. The patient also should have a good mouth opening when you're doing your zygomatic implants. So let's understand this whole procedure by looking at a case. So I'm going to show you one case of how, I'm going to show you multiple cases of zygomatic. So first I'm going to show you a single zygoma. Then I'm going to show you quad zygoma. Both of them will be done freehand. Then I show you a quad zygoma, which is done with a guide. And then finally I show you a case in which my tilted implant failed and I went ahead with zygomatic. And in that case, we did one freehand and one guided. So kind of like a split mouth study. So this is a patient who walks in, and he has obviously tissue support is not there, low lip line is present, and the patient has been edentulous for a very long period of time, and you can see that there is a lot of atrophy in this patient. So like I said, you need to evaluate if the sinuses are healthy. We take the CBCT. And when you are going to opt for such extensive surgeries, what I like to do is always do a mock-up. Even if I'm doing a freehand surgery, getting a stereolithographic model, practicing it outside, understanding the anatomy beforehand makes a lot of difference. It relieves your tension and makes you a little more confident while you're actually going for the procedure. So here we had the stereolithographic model. We prepared the model. We understood the anatomy here. Now, the most important aspect of doing your zygomatic implants, when you're doing your zygomatic implant, your first initial drill, where you start your drill, what is the direction that you take, is the most important. So let's say if you're doing a single zygoma, your first point of entry, what I like to call it as a point A, has to be somewhere in the second premolar region. Then you have to identify where is the exit of the zygoma. The exit of the zygoma, if you're doing a single zygoma, ideally it should be right in the center of the zygoma. However, even though you're doing a single zygomatic implant, try not to keep your exit right in the center, right? Not between your orbit and your lateral border or the lower border of the zygomatic bone, but try to keep it closer to the lower border of the zygomatic bone. What is the advantage? There are two advantages when you're exiting it a little lower. One, you are away from the orbit, so chances of you damaging the orbit is minimized. And second is, if something goes wrong at a later stage, you still have got enough real estate to go ahead and place your second zygomatic implant. If you place it right in the center, you really are going to be stuck. So always, even if you're doing a single implant, try to keep your exit point of the zygoma a little closer to the lower border. So as I said, you start by making a notch. I take my round burr, I make a notch in the second premolar region. What we follow is the Zaga protocol. Not going too much into the depth of Zaga protocol. There are 5 ways that we can do Zaga 0, 1, 2, 3, 4, and depending that will which the protocol you take will really depend on the concavity of the lateral wall of the maxillary sinus. So in any case, you start by taking your first purchase point on the crest and the region of the second premolar region. Then comes your entry inside the zygoma, and that is your point B. Now, this point B will vary depending on how your zygomatic bone is. If the patient has got very high cheekbones, your point of entry becomes a little higher. If the patient has got severe atrophy, again, the point becomes higher. So that will vary from patient to patient. So again, getting this stereolithographic model made will really clear up a lot of doubts when you before you actually enter the surgical field. So make the entry point at point B. Now, once the point A and point B have been identified and a round burr is taken to make ditches, then you pick up your diamond burr from, like, for example, like I do from Norris, you create a tunnel. So by joining these 2 points, you create a tunnel. The reason why these burrs are diamond is because when they come in contact with the Schneiderian membrane, the maxillary sinus membrane, it does not perforate the membrane because it is diamond. It also helps you create a path through which your drill is going to go ahead and pass. So after the tunnel has been created, you take your long drills and start your drilling. Now, what you have to understand with these drills is that these drills are long. The longer the drill, now if whoever has joined and has been doing implants will understand that the longer the drill, the lesser you have control. And if you have a short drill and if you have minor deviation, you will not have too much of deviation at the apex. But if you have a longer drill, any minor deviation means that there is going to be more deviation at the apical region. So be very, very careful when you're doing your drilling with these extra long drills. After you go ahead, now you need to perforate, go inside the maxillary sinus and locate the zygomatic bone, drill through it and get your exit point. To determine where your exit point is there, if you're doing a freehand, now this is a blind procedure. If you cannot really see the exit of the zygomatic bone. So what I'm going to do is you're going to keep your finger right here while you're drilling, and you need to make sure that your drill comes out of the zygomatic bone. Once that is done, you go ahead and take your depth probe. Now, there will be a lot of temptation for you to take your drill a little more back to get more and to take your drill, to take your point of entry more posteriorly. The more posteriorly you go, the straighter your drill becomes and you become more closer to the orbit. Like I told you here, in this stereolithographic model, what you can see is that my drilling is done and my point of exit is right in the center. So like I told you, this was one of the early cases that I did. Today, if I have to do this drilling, my direction would be such that my point of exit will be more closer to the lower border of the zygomatic bone. So you need to go ahead and drill and you need to palpate while you're placing your implant. This is the final placement which is done. So now let's look at the case here. So this is the patient here. We give our intraoral blocks, and we also give extraoral blocks like your zygomaticotemporal and frontozygomatic block anesthesia. You start by giving your simple mid-crestal incision. You can slightly give it a little more palatal to increase the bulk on the facial aspect. You give one vertical releasing incision on the distal and one right in the midline. My suggestion would be not to open up both the sides. First complete one side and then go for the other side. Usually these patients do not require any kind. The reason why we do both sides together in our regular patients are, we need to create a base. In these cases, usually the patients will come with severe atrophy and you really won't have to create any base. So just start with one side, keep it atraumatic, open up the flap in such a way that you can expose the lower border of the zygoma. You can go all the way up to the floor of the nose so that the vision is good. Not raising a good flap means it's inviting trouble. You need to see what you're doing. So raise the flap, identify point A and point B like I mentioned to you. Once the point A and point B is identified, now you take your diamond burr, join them together. Now, before you go ahead and start doing your drilling, take your depth probe, place it on the outer surface of the face, and then see if it is parallel. Now, that depth probe is kept in such a way that it is not coming close to the orbit. So this is again a good indication for you to be very, very careful. Once the tunnel is created, you go ahead and elevate your Schneiderian membrane. Now, this is optional. If you can do it, go ahead and do it. If you cannot, it's all right. Once it is done, we go ahead and take our the zygomatic drills. We start the osteotomy. The osteotomy is done. We determine the length with the depth probe. We go ahead and place our implants. Now, in this case, I also did my nasal lift and placed axial implants. Today, if I have to do this case, I would probably not do this. Probably I'll do my transnasal. So anyway, in this case, I went ahead and separated my nasal mucosa. Lifting of the nasal floor mucosa is very, very similar to your sinus lift. In fact, it is actually a little easier than sinus lift because the membrane is much thicker as compared to your sinus membrane. So I went ahead, lifted up my sinus nasal membrane. I went ahead and did my drilling, placed my membrane in this, placed some graft material, placed my implant, did some contour augmentation, placed my multi-unit abutments, placed my healing collars. And this is the immediate post-op. The patient had a denture. I converted the denture. Again, today, I would probably not be doing this because if you are converting a denture, you really are giving a very weak prosthesis to your patients. You cannot afford to have any kind of micro movements with your zygomatic implants. So today, this would not be my choice of prosthesis as a temporary restoration. And we'll talk about what I really prefer these days. So I converted the denture. I got the one screw test. The prosthesis was passive. The access holes were sealed. This is a maximum intercuspation. And that's the post-op OPG. You can see that even though it's a freehand placement, the drillings have been fine. There is a sufficient distance kept from the orbit. And this is the patient immediately after the surgery. And straightforward case, no extensive grafting, and a visibly happy patient. Now let's talk about a freehand quad zygomatic. So if you have no bone present in or any of the zones, you can go ahead and place your 2 zygomas on each side. So this was a lady she's relatively young and she has lost her teeth at a very young age. She's been wearing a denture for a very long period of time. You can see the amount of atrophy in this patient. Now, when you talk about quad zygoma, you're placing 2 implants. So the point A, the point of entry for your anterior implant will be somewhere in the canine region, and your point of entry for your second implant or the posterior implant will be somewhere in the first molar region. So again, in this case, we went ahead. Everything else remains the same. The only change that we have is the point of entry. So we do a freehand mock-up. First, we do a mock-up. This is the pre-op. I start my drilling. First, the posterior, then all the anterior. Place all the implants together. Now, these implants. Now there is so much of atrophy. Now this implant that I use is from Norris. So there is a long, smooth collar which is present here. The reason being that even if the tissues retract, even if the implants do get exposed in the oral cavity, the patient will not have any peri-implantitis issue. To ensure that things are the healing is good, I went ahead and placed some PRF over the zygomatic implants. I placed my healing collars. Again, in this case, I converted the denture. Again, not the choice that I would do probably today. This is the patient after 6 months. Now, I'm not usually in a hurry to complete my prosthesis for my zygomatic implants within 3 months. I really like to wait for a good 6 to 7 months before I actually load my implants. There is a study that shows that the maximum failure of the implants happened within tilted implants happen within first 1 year. So if the 1 year the implant survives, the chances are that the failures are going to be lesser. So with your zygomatic implants, I do not like to go after 3 months, 4 months. I like to wait for 6 to 8 months. And with the kind of temporary prosthesis I give these days, the patients are ready to wait, because if you give a prosthesis which is denture conversion, which is where you've done a denture conversion, the patients will break and come back, and then they will be in a hurry. But if you give them a little more sturdier prosthesis, they will be ready to wait for a little more longer period of time before you transition them into final restoration. So anyways, today we go ahead, we start with the impression, we do the PMMA, and we give this beautiful final restoration, which is titanium framework with individual zirconia crowns, maximum intercuspation, check the occlusion. And that is how we finished this case for this lady. That's how we started, and that's how we finished the case. And she was, more than her, I was relatively happy because everything worked out in my favor. Let me show you one more case. Now I'm showing you a quad zygoma, but here we are going to go ahead and do a guided approach. Now, zygomatic implants, now when you're doing your regular implants, you are not really playing with a lot of anatomical landmarks. But here you have your temporal fossa, your infratemporal fossa, you have your orbit, too many things. And if someone does not have that kind of surgical background, it is kind of scary. And trust me, it is scary. You are I still have palpitations when I'm doing my zygomatic implant. So it becomes very, very convenient to go ahead and do a guided protocol with your zygomatic implant. So let me show you how we go ahead. So this was a patient, she walked into a practice. She had a history of implant placement somewhere long time back, but those implants failed. And now she has this severe atrophy. Then she comes to me. So failed upper arch, literally no bone to play with at all. You can see the amount of atrophy that she has. She literally has no maxilla, which is present in her mouth, but she has good clear sinuses, and thankfully she has got a good zygoma. Now, there are times where your patient also will have small zygoma. In such cases, even a quad zygoma becomes very difficult. So in such cases, then you have to think of other options, or that's your customized implants or your subperiosteal implants. So evaluating in the CBCT of, you have to also see whether the patient actually has that kind of zygoma or the real estate to engage to implants in that area. So when you're going for the guided protocol, you want to make precise guides. So in such cases, your regular CBCT are of no value. You need to send the patient for a CT scan of medical grade. You need to make a denture with either radiopaque teeth or radiopaque markers, and the patient, like any guided protocol, goes for a dual zone, a dual grafting, too much into grafting, dual scan technique, where there is a scan once which is done with the guide and with the denture in the mouth, and then the second is with just the denture. So we go ahead, we start with the scan for the patient, and then we plan it on the exocad. Once the planning is done, we give the patient anesthesia. This is the occlusal view. Again, like I said, we start with one side, we open up a flap. Now, understanding, just because you're doing a guided, now this guide is not mucosa supported, it is bone supported. So if you are talking about any bone supported guide, it requires a lot of reflection. So go ahead and reflect it thoroughly. And now this is the guides which have been fabricated in India. These are make and milled, as it is called. These are 3D printed stents. And these come in two parts. So one is your tunneling. So if you understand that we did it in two parts, first we did the tunneling and then we did the drilling. So this guide tells us exactly how much to tunnel, where to tunnel. Not only that, the second part of the guide gets over the first part. So when you are drilling through that hole, there is literally no deviation and the chance of errors are very, very less. So I have found these guides very useful. So I first place my tunneling stent. I'm showing a mock surgery and the clinical pictures together. So you place your tunneling stent with your osteosynthesis screws. Once when the screw has been stabilized, you take your diamond drill and start doing your tunneling. Your tunneling has to come. How will you know that your tunneling is done? Your tunneling will be done when your diamond burr touches the end of that of that stent that you have created here, of which you have got it made. So once the tunnels are made for the first and the second one, so you can see here the tunnels are created, the Schneiderian membrane are not damaged at all. I place my second stent, that is my drilling stent, over it. Now you can see that we have lovely slots which are going to fit exactly with the diameter of the kit that we have. We stabilize it, and now the drill is going to go through this stent and go ahead and engage the zygomatic bone. Then you can go ahead and place our implants through these stents. Once the implants are placed, we remove the stent, and you can see this is how we have planned. This is how we finished the case. This was quad zygoma. Of course, today, if you want to do this case, you can also supplement this case with adding 2 more pterygoids to increase the AP spread. So again, done a long time back. So the multi-unit abutments placed. Now, the best part of doing these zygomatic implants is, even though the surgery is very different, the prosthetic part becomes exactly the same. So if you're doing somebody who's doing all on 4, your prosthetic part is sorted. You just have to master the surgical part. So once the implants are done, we place the PRF here. I get my good closure. This is the ideal placements. We go ahead with the open tray. Again, today we might think for digital. The planning is done on the software. Now, in this case, I have opted for the next best solution, and that is my PMMA. So we do the PMA, the pickup of the PMMA, and this is for the long term. You can see this is being made very, very beautifully. Not only that, the intaglio surface is nice and convex. And most importantly, look at the thickness of the temporary. The temporary has to be at least this much thick. Let the temporary be a little more bulky. Inform the patient that the final restoration will be a little less bulky, but in the temporization phase, you do not want any kind of micro movement. So we go ahead, give a nice bulky prosthesis that does not break. This is the with characterization. Prosthesis was passive, checked for maximum intercuspation. This is the immediate restoration of the patient. And this is immediately after the surgery within 3 to 4 days. And then we, of course, changed the prosthesis from the PMMA to, again, titanium with zirconia prosthesis. This is a maximum intercuspation. That's how we started. And that's how we finished the patient. This is the initial situation and a final situation. Now, let me show you one more case in which zygomatic implants actually helped me. So look at this case here. Now, this patient really had really poor luck. He came to me. Just a second, minor.
गाड़ी भी चलाने जाएंगे अभी अपन तो
Is it seen?
Yes.
Just give me a second more. I'll start sharing in a minute.
Please, while waiting, any questions, don't forget to just post on the chat group. Then we can ask at the end of the lecture. Thank you.
Well, is it seen? All right. All right, so this patient really had very poor luck. Poor thing, he went, he already had a history of failed implants. He comes to me and you can see that there was a major defect in the anterior aspect and there were some implants that were failing. We went ahead, we started by fabricating his denture, his occlusal plane was reversed, we corrected that, and then we fabricated the, we made the stereolithographic model, we did a mock-up surgery, and we gave the anesthesia, opened up the flap, removed those failing implants, did our tilted implants, our axial implants. On one side, I did freehand zygomatic implant, created a tunnel, did my osteotomy, placed my implant. Everything was hunky-dory, final placement done, good stability, placed my multinode abutments, placed my healing collars, took an open tray impression, and gave the patient a lab fabricated temporary. Now, even though I've given a lab fabricated temporary, you'll understand that over a period of time, things go wrong. So here, this is the immediate post-op CBCT, beautifully placed. Everything was fantastic. I was really, really happy. And then when the patient came back after a period of 5 months, this tilted implant failed. And I think the reason why it failed was the temporary that I gave him was very, very weak. It is quite possible that that led to micro movements and eventually this implant failed. So once this implant failed, this was a time where really COVID period was there, and when he came, we just removed the implant. There was some amount of granulation tissue. We removed the implant. The patient said, I really don't want to go with any kind of surgery anymore for some time. Give me some time to mentally prepare myself. So we just went ahead, placed the implant. Let the tissues heal. He comes back after 3 months. And after 3 months, he really had a lot of, he really thought about things. He said, what, he came to me. And, when he came to me, I was like, oh my God, why do I explain to him that things have really gone down south? Because when I look at his x-ray, I see that there is, again, a major defect which has been created, and doing another tilted implant is going to be very tricky here. So I was thinking, how do I really communicate? Because I'm sure that all of you listening to this webinar, the difficult part of failure is not really managing the failure, it is managing the patient. So when this patient came to me, I was wondering, how do I really take care of this patient? The best part was this 3 months, the patient had started to think. He said, comes to me and he said, doctor, I think conventional implants, small implants don't work with me. I think only zygomatic implants work with me. I said, fantastic. I didn't have to convince this patient at all. And he agreed to go for zygomatic implant without me convincing him at all about the surgery. In this case, now we went ahead and did our guided protocol. We fabricated a guide. We did a water model done. This was the guide. We did a mock-up surgery, gave anesthesia, opened up the flap, placed the guide, went ahead with the diamond bore, created the tunnel, placed the second stent over it, did the drilling through it, placed the implant through it, and got good stability. Because we got good stability, I could immediately load this one implant and the remaining 3 implants which are already integrated, start with my impression. And then this case, I was now smart. I did not give the patient a weak temporary, again, a mild temporary, which is strong. We did the pickup technique, and this was in maximum intercuspation. This is the right side, this is the left side, and we temporize the patient for 6 months. And more than the patient, it's me who is happy at this stage. Now coming to the next part, and that is my pterygoid implants. What are pterygoid implants? Pterygoid implants are those implants that engage the dense bone of the pyramidal process of the palatine bone and the pterygoid process of the sphenoid bone. Why do you want to go for pterygoid implants? And for the longest period, I was not a big fan of pterygoid implants because it is a relatively blind procedure. So first and foremost, why we want to go for it? The most important reason is to avoid cantilevers. Now, patients expect teeth right up to the back, and they usually is pneumatization. If you do not give your pterygoid implants, you end up with this kind of cantilever, like you can see in this case of mine. And we know that in literature, it is said that the worst thing that you can do for your patient is give cantilevers, because it can cause excessive loads on the terminal implants. You will also go for your pterygoid implants if you want to avoid sinus slip. Why do you want to avoid sinus slip? The patient does not want to go for sinus slip. There is some active infection, the patient suffers from sinusitis, or the patient has previous history of sinus slips which have failed. So in these cases, you will go ahead and do your pterygoid implants. And again, we are living in an age where everybody is looking out for immediate loading. And again, we know that getting good primary stability in the maxilla is very, very difficult. Usually patients come with very, very soft bone. And what we really desire in our full arch cases is to get a composite torque value, the total torque value of all the implants up to 120 Newton centimeter. By placing your pterygoid implants, what you can ensure is that every time you place your pterygoid implants, you get high primary stability, and immediate loading becomes very, very easy for these patients, because your pterygoid implants give you excellent stability as it anchors in the dense cortical bone. The cortical bone in the maxilla and the posterior is your the pterygomaxillary junction. If the patient has a wide smile, if you end up placing implants only in the anterior part and doing simply an all-on-4, and the patient smiles, it is going to be the patient will have some kind of a black triangle in the buccal corridor region. When do you not go for pterygoids? When you do not go for pterygoids, if the patient has a supraerupted tooth, if the patient has difficult mouth opening, or if they have an impacted third molars, these are the times you do not go for pterygoid implants. Now let's get into the surgical technique here. First and foremost, you require a special kit. Now in this kit, again, I'm using Norris Medical. So I have in this kit, a pterygoid kit, I have a sharp osteotome, I have a blunt osteotome, I have long drivers, and I have a long drills. I have long drills here. So where do you start? Now the first step really is to go ahead and palpate your hamular notch. When you're palpating your hamular notch, your osteotome has to be 8 to 12 millimeter anterior to this hamular notch. The deciding factor really about the angulation of your drill will depend on your posterior wall of the maxillary sinus. Your initial point will be somewhere in the half or 2/3 of the crest of the buccal of the ridge. And if these angles are a little more confusing, because somebody like me who's very, very mathematically challenged, I find it very difficult to understand the angles. So in this case, what you can do is imagine a clock situated just posterior to your, somewhere in your maxillary tuberosity region. And your drilling has to start from the buccal, and it has to be 1 hour medial. If you imagine a clock, it has to be 1 hour medial to the 6 o'clock position. Your direction has to be in the posterior medial and the superior direction. It has to be posterior to the posterior wall of the maxillary sinus. Always start first with the osteotome. Always start with a sharp osteotome first. so that it can easily go through the maxillary tuberosity region. Do not try to go with your drill first. First, create a path, then go ahead with your drilling. Now, the sequence of osteotomy for your pterygoid implants is always start with a sharp osteotome till you feel. Now, when your sharp osteotome progresses to the maxillary tuberosity, it's going to be extremely soft. The first hard bone that you feel will be the pyramidal process of the palatine bone. Once you feel that hard bone, now switch to your 2mm drill, because your osteotome is not going to go through that drill, through that bone. Now take a 2mm drill to go through that pterygomaxillary pillar. Again, go with a sharp osteotome to widen and condense the bone of the maxillary tuberosity. Then go ahead and take a blunt osteotome and tap. Now, when you tap, unlike your sinus lift tap, where you go tap, 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 don't go tap, tap, tap. Go tap, 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 because you are going to get your tactile feeling. You're going to hear the noise. So when you actually go in the dense bone, the sound changes from the soft tuberosity, maxillary tuberosity bone to the hard pyramidal process of the palatine bone. When you're talking to place about placing your pterygoid implants, you require special implants, which are cutting implants, which are sharp at the tip, which are tapered. So this is one, again, the implant that I use is from Norris. This is called a Sterifit, which has got a smooth collar and a very, very sharp tip and a sharp apex. So this is the direction. Now, one of the things to understand is that your drill, if it is, should be coming at the angle of the mouth. If it's coming out to the angle of the mouth, most likely your direction is correct. This is just a clinical tip, and that is how you place your implant. You can either open up a flap and do it. Some practitioners like to not raise a flap at all and then do the drilling. So it all depends on really on you. So you go ahead and do your drilling. And in the clinical tip that I would like to give here is that try to use your straight handpiece. Using a contra angle handpiece can be very, very tricky. Sometimes you can also go ahead and fabricate a guide, just a pilot drill guide. I have tried using this and I found it absolutely useless. Maybe I was not accurate about with my CBCT, or the lab was not efficient enough to fabricate this guide. But I have tried this once and it has not really worked in my hand. So the points to remember is do not under prepare. One of the things that you can do, the maximum damage that you can do is under preparing it too much. If you under prepare that area too much, you might actually fracture the pterygomaxillary region completely. As I said, use sharp implants, use a straight handpiece and a longer implant driver. So having said that, let's look at a very small video of implant placement for the pterygoid implant placement. This does not have any sound, so just go ahead and have a look. So you start by taking your sharp osteotome. Now, this is not the osteotome from the kit. This is an Indian-made osteotome, which is like a lancet, right from start to end. There is also in India, there is something called a Stotza, which is available, which is pioneered by Dr. Shyam Mahajan sir. So you can try that. So after this first drill, first osteotome, which is sharp, once the path is created, now I take my drill so that I can engage the pterygomaxillary junction. Now, this is something that you do not want to do. Do not wriggle your handpiece too much. And now you can see here that I'm taking my blunt osteotome now and start tapping. Initially, the resistance will be less because it is going through soft tuberosity region. And the moment it reaches the junction, you're going to feel the resistance. Then, as I said, go ahead and take your pterygoid implant. You require a longer driver here. Are we okay extending it a bit, or should I just... Thank you. So like when you start placing your pterygoid implant, you are going to feel initially no resistance because it is going through the soft tuberosity bone. And eventually you're going to get good primary stability. In fact, you'll get stability up to 60, 70 Newton centimeter torque. If you're getting too higher torque, do not progress, because again, if you try to, it's hard cortical bone. If you get too much torque, the entire area will fracture and you will not be able to place your pterygoid implant. So if you think that you're getting too much of resistance, take it back, unturn it, and then turn it inside again. So just like we do 3 turn in, 1 turn out, not 3 turn in, 1 turn out really here, but take out the implant a little bit and then progress ahead. So the debris also gets cleared and your implant can progress easily. So a very useful and versatile tool here is to have a long torque implant driver here, as you can see. So if the patients, you cannot go all the way to the back and try to ratchet it inside. So this becomes very easy. I know of clinicians who do this without exaggeration in less than 5 minutes. So for someone who is very comfortable doing pterygoid implants, it's very easy. I think half the fear is in our heads when we are doing pterygoid implants, and I'm talking this with personal experience. Once you start placing, you realize that it is not as difficult as it looks. So that's how you go ahead and do your pterygoid surgery. Of course, the prosthetic part still remains the same. You need to have angulated abutment. You need 17 to 30 degree multi-unit abutment for treatment of your pterygoid implants. So let's look at this one case here. This patient comes to me, severe atrophy. Then somehow I attract these patients in my clinic. All the patients who come in, they usually have no bone. They have money, but they have no bone. So what are the options that we can offer this patient? We can do a regular all-on-4, but again, it will increase the amount of cantilever here because the pneumatization is a lot. We can go with 2 transnasal, 2 zygomatics. We can go with 2 transnasal, 2 zygomatic, or 2 pterygoids, or we can go with a combination of nasopalatine, transnasal, tilted. A lot of options can be given here. So in this case, we went with a transnasal. I'm going to talk more about transnasal. We go ahead. I lifted up the sinus, the nasal mucosa. I did a freehand zygomatic placement, did a flapless pterygoid placement, and placed my implants, got good placement. This is the immediate post-op. Did my scan, jaw relation, got my provisionals. Now the provisionals have changed. I am having a metal bar which is joining all my implants together, so chances of micro movements are less. And you can see that just by doing my pterygoid implants, I'm reducing the cantilever. You can see if had I not placed my pterygoid implants, I would have a very long cantilever here, and here, because I'm placing my pterygoid implants, the patient is able to have more teeth to chew with, especially in this case because the patient has natural dentition. So the occlusal loads are going to be higher. So this is the final temporary restoration, of course, for the final. This is her smile. This is post prosthesis insertion. This is how we started, and that's how we ended with the case. Let's talk about trans-sinus. Why do you want to do trans-sinus? As the name suggests, trans-sinus means goes through the sinus. Now, when we are typically doing our all-on-4, our implant placement should be somewhere in the second premolar region. And then we can have a very small little cantilever in the molar region. But if the sinus is pneumatized, and in almost 70% of the patients, you see that the sinus pneumatization happens all the way to the canine. So in that case, we end up with very long distal cantilevers. So in such a scenario, what is the other option? The other option is to go ahead and place one implant that goes through the sinus, and you have a smaller cantilever. So what is the benefits of doing a trans-sinus? You get tricortical stabilization. Stabilization from the crest, from the floor of the sinus, and the anterior wall of the sinus wall. What are the problems with trans-sinus? First and foremost, the surgeon has to be experienced. It is not as easy as it looks. Also, you should have at least 3 to 4 millimeter of residual bone height. If you do not have even that much, the chances are that you are having just one plate of cortical bone here and one plate of cortical bone on the top, and the whole of your implant is in the sinus. So that becomes a big problem for the initial primary stability. So what are the points you need to take care? If you want to go with trans-sinus, at least look for a case that has 3 millimeter of residual bone height. Some studies tell you to go for at least 4 millimeter residual bone height. Do you do a sinus lift? Do you do your graft? Well, that will depend again on whether the patient has got a healthy sinus or not. If the patient has no sinusitis, just go through the sinus without any problem. If the patient has got sinusitis, do a lift laterally and then place the implant and put some graft material. So let's look at the surgical technique. The surgical technique is quite straightforward. It's very similar to all on four. The only difference here is rather than you coming in ahead of the anterior wall of the sinus, you're going to go through the sinus. So you start from the crest at an angle of 45 degrees, engage the anterior wall of the sinus, complete your drilling, and then place your implant. If you have 3 or more 3 millimeter or more amount of bone present as a residual bone height, just place your implant. No need to do any kind of sinus lift. If you have lesser than 3 millimeter, along with placing your trans-sinus implants, you also need to graft just like you would do with your lateral sinus window technique. What are the problems with trans-sinus technique? It is seen that there is high chance of screw loosening, and the chances of oroantral communication is higher if the residual bone height is very, very less. Now let's look at the trans-nasal implants. What are trans-nasal implants? As the name suggests, trans-nasal goes through the nose, and it engages the junction of the inferior concha and the maxillary bone, or your Z point. Let's directly come to the surgical technique. Look at this patient here. She has got severe atrophy in the maxilla. This is a pre-op situation. We start by, the lower arch was done with a guided protocol. This was for the upper arch. This is the facial CT. We do a mock transnasal. Now let's understand how to do transnasal. I think this is, amongst all that I have showed you, I think this is something which is very, very doable by anyone. And this is currently my most favorite technique. If you talk about all the remote anchorage implants, this is a technique I really love. So in such case, I first fabricate my STL model. Like I told you, identify the inferior concha, identify the junction where you want to go ahead and engage your implant, and that is your Z point. In this case, the patient had a lot of excess bone, so we just went ahead and cut it, created a simple base. Now, your entry point for your transnasal implant is somewhere in the lateral incisor region. All right, so that is where you start. If the patient has a lot of atrophy, come a little more palatal. Let the implant have a little more palatal bias. So you start at the lateral incisor. You go ahead and perforate the nasal floor. Now, obviously, before you do this, you have lifted up the nasal mucosa all the way till you can identify the junction and the first hard point that you meet, that is your inferior concha. So go ahead, reflect the mucosa till there, perforate the nasal floor, and let the implant be close to the lateral wall. Don't let it come to the medial part. Let it drill hugging the lateral wall of the nose. So once that is done, engage the Z point. Now, obviously, the implant is not going to be exposed in the mouth like this. This is a model, and that is why the drilling is like this. Now, the question really is, after we have done this, do we go ahead and graft? We have done a lift. Do we need to graft that area? Now, depends on what study you have, what study you see. Some studies say that if you're doing a nasal lift, you need to graft that area. However, there are some other studies that tell you that if you go ahead and do your nasal lift and also graft, you decrease the airway space, and the chance of oronasal communication increases with your grafting. So let's look at the mock zygomatic. I think mock zygomatic we have already seen, so I'm not going to talk too much about this. The same thing, first we have the tunneling stent, then we have the drilling stent. So this we have already covered, so I'm not going to really waste your time talking about this. We have already gone through this. Let me directly come to the surgical part. This is how your implant should look at the end of the surgery. 2 transnasal, 2 zygomatic. So look at the clinical picture here. We start with the incision. We open up the flap. I lift up the nasal floor. I understand where my inferior concha is. Do the cristotomy, create a shelf. Exactly what we did there. With the lateral in the incisor region, we go laterally. Do not go straight. Go laterally and engage. You're going to obviously go to see the drill while you're drilling it in the nose. Go ahead and do your osteotomy. And after that is done, on both the sides, go ahead and place your implants. Typical length of implants here, you'll require a 16 to 18 mm of implants. This is the final implant placement. I did not graft in this situation at all. And of course, for the zygomatic, we went ahead with the guided protocol. So again, not discussing too much about it. We have already gone through this entire placements protocol on both the sides. So this was my placement, 2 transnasals, 2 zygomatic, multiple abutments, remove the excess tissue, go ahead with my scan. This is the final post-op CBCT, scanning, taking a bite of the patient, send the data to the lab, They go ahead and design. Now, this is what I really like these days, making a bar which joins all the implants together, and then a cementable overlay over this bar. So that is how we started. That is how we completed the case. This was the before, and this is how we finished the case. Now, there is a video here, but I think we will just skip the video. We are really running out of time with this seminar. I had this video made, which is showing the transnasal and the zygomatic here. So if I'm permitted, I can show the video. If not, if there's a thumbs up, I go ahead. If not, then we just go ahead and conclude the discussion. It's a trick question. Okay, so I'm going to make a vote. Should I go ahead or should I skip? So I want everybody to chat on the chat to write. Should we go ahead or continue with the video? Continue. Okay. You know what? We are okay with it. I hope you're okay. All right. So let's go ahead and see this video. All right. So a lot of questions here at this stage. Can we do a quad zygoma in this case? Yes, could. But I think the transnasal implants is one of the solutions for not doing a quad zygoma. A quad zygoma should be reserved for only cases where nothing can be done. So if this patient later on develops a complication, yes, you can definitely opt for a quad zygoma. The second question that I was seeing was, how do you cement it? You cement it with the temporary cement. The cementable overlay with the titanium bar has got a very good fit. So even with your temporary cement, it stays. And the cementable overlay has access holes. So you can later on remove the entire prosthesis. So although it is cemented, it becomes screw retained. You can completely retrieve the prosthesis. Coming to the last part, and that is the complications. Different complications in transnasal implants could be that you block the nasolacrimal duct while you're placing your implant. If you block the nasolacrimal duct, the patient has something called as epiphora, that is excessive tearing of the eye. And then the patient has to undergo a procedure where the opening of the nasolacrimal duct is shifted from the inferior meatus to the middle meatus. The patient can have certain transient paresthesia of the ala of the nose, of the nose, and which gets resolved usually in 30 days. Also, sometimes a patient will complain of minor respiratory obstruction if the patient already is suffering from nasal septal deviation. And if you go ahead and graft this area, the chances are that the patient can also develop oronasal fistula. So I try and avoid doing my grafting when I'm doing the transnasal implant. Now, the entire presentation I'm going to complete with showing that one complication that really harrowed me a lot, because, and you know, this proverb really stands true for it. It never rains, it pours. So here, this patient comes to me. She's a very well-educated, very nice lady, but with severe atrophy. You can see that there is literally no bone which is present, no bone for conventional implants. Thankfully, good sinuses. In the lower also, there was less bone. So we went ahead with the tilted implant protocol, straightforward case. In this case, now we went ahead. We wanted to do a quad zygoma. We do the, for the guide fabrication, we go ahead and send the patient for a facial CT, do the entire planning on the software, fabricate our guide, do the mock surgery, open up the flap, do my placement, do the drilling, quad zygoma placed. This is how we finished the case. But when I saw the X-ray, so, you know, sometimes your guides can be tricky. So here, even though we went with the guided protocol, you can see that we made some errors. So it is quite possible that the acquisition of the CBCT was not accurate. Maybe the patient moved during the CT scan. And, you know, these are the points that you have to understand when you're going with the guided. So guided is not the ultimate end point for you. You have to understand that there can be complications even though you go guided. So in this case, excessive extrusion. So understand when I'm looking at this implant, most of the implant is smooth. Only the apical 10 to 12 mm is the one which is threaded, which is engaging my cortical bone. When you're placing a zygomatic implant, your implant has to be extruded only by 1 millimeter or so. If it extrudes a lot, the patient can develop a fistula. In this case, we obviously lost the stability. The patient came back within 3 days. This implant was out. I placed another implant by changing the direction. Now, this is within the 3 days that we've called the patient. Within the 3rd day, the implant was moving. So I changed the direction. I placed, we got good stability, and we gave the patient temporary. And I was thinking, okay, you know, things are working out fine for me. This was the final post-op of the patient. And when the patient came back the next time, she went to US for 6 months. She came back after 6 months. These 2 implants failed yet again. And now I'm in a quandary as to what really has to be done here. So here, what you can do is you can wait for a few more months and then come back and attempt. In this case, what we did was, in this situation, now we had to go with customized implants or the subperiosteal implants. So we gave a little extra oral incision. We stabilized with titanium screws. This was done, of course, with the help of my oral surgeon. This was not done exclusively by myself. And this was the final placement. We went ahead and sutured it. This was the immediate restoration again. This is 6 months later. This is the upper and the lower final restoration. That's how we finally completed this case. And more than me again, more than the patient really, it was me who was relieved with the entire case coming to a fruition. So what are the take-home points at the end of this 1.5 hours that we have spent together is that extreme grafting may not be always the solution for all your patients. Severely atrophic jaws can easily be treated with zygomatic implants. Patients come for teeth, not for your awesome surgical skills. Understanding anatomy, thoroughly understanding anatomy is the key to success in remote anchorage implant surgeries, because these surgeries are done in areas which have a lot of significant anatomical landmarks. And if you want to be very careful, do your mock surgeries before you attempt it actually in these high risk category cases. Guided zygomatic protocol can make the procedure much more predictable. Immediate function loading is a fantastic practice builder. It can change your practice, and it offers an exceptional option to our patients to be rehabilitated easily without any extensive grafting procedures. Although surgery is different, the prosthetic part or the prosthetic steps remain the same for your remote anchorage implants. Immediate loading is preferred in zygomatic implants. In fact, it is seen that if you do not load your zygomatic implants immediately, the chance of failures are higher. Understand that remote anchorage implants are not your regular implants. It has a very steep learning curve, primarily because you're not going to get these cases. You're not going to be able to practice these cases very, very easily. And the conclusion is that when you are going to start doing all these kind of implants, you're going to learn, you'll have to go ahead and learn a new skill. And this is going to be difficult. But understand, if you're not willing to learn, no one can help you. And if you're determined to learn, no one can stop you. The work you're doing is actually the signature that you're leaving in your patient's mouth. And by doing these implants, you're really stepping out of your comfort zone. But understand that taking when you're taking the first step is always going to be difficult when you're stepping out of the comfort zone. Life begins at the end of your comfort zone, and the first step is always going to be the most difficult one. But understand, at the end of the day, this journey is going to be well worth the effort. So with that, would like to say a big thank you to all of you for kind hearing, for being so patient so late at night. Thank you very much. This is where you can contact me. So thank you, Implant and Aesthetic Study Club. Thank you, Laurie. Thank you for being here, for being so patient.
Thank you, Komal. Very impressive lecture. Amazing to see the type of surgery you're doing. And I think a lot of people don't even know that you're not a specialist, but a general practitioner. So it shows that it can be done. I love the way that you put thought into every single step that you're doing in the procedures. We do have a few questions, and given that I'm sure it's past your bedtime, I'll try and get through that quickly. I'll start with the last one and work my way up. The first one was from Priya Singh, saying, in the lower, I'm not sure if I'm understanding this, if thin ridge till 12 to 13 millimeter length, then 5 millimeter width started for 12 millimeter length, what would be the treatment if fixed treatment is needed?
Ma'am, in lower of thin ridge till 12 to 13 millimeter length, and then 5 millimeter started from 12 millimeter. I'm not really getting the question, unfortunately.
Okay, I thought hopefully you would know that better. Maybe Priya can ask it again.
She can message me separately.
Okay. Jalal wants to know, how do you avoid damage to the zygofacial nerve?
Well, understanding the anatomy, doing the mock surgeries, I think that would really avoid damage. That's all you can do. But be careful.
And
also you have to understand that the middle part of the zygoma is a relatively safe region. The zygomaticofacial is a little closer to the orbit as compared to in the center. So damaging this is going to be a little tricky. So just do your planning properly, do the mock surgeries, get a model. Chances of damaging is less.
I had a question here. Do you ever, especially with your zygomatics, do you ever use the denser drills, given that they generally have less chatter and less heat generation? Do you use them or not?
No, I have not used Densa for Zygomatic. They are currently not available in India. And I did happen to look at them during the EAO. However, the problem with the Zygomatic drills is they are internal irrigation with Densa. They are internal irrigation. So they recommend them to be used as a single-use drill. So that could be a problem for a lot of practitioners. But yeah, definitely reduce the chatter. But I, honestly speaking, don't see the rationale of using a Densa burr in a dense cortical burr.
Okay, and then Dr. Brinda's asking, would you use extraoral anesthesia for pterygoid implants?
No, only for zygomatic. Your regular posterior superior alveolar nerve block would be enough with your pterygoids. Even your infiltration would be enough.
I see some of these cases. Do you ever do soft tissue grafting to improve the attached keratinized tissue around the cases with the severe atrophy?
I have not yet done, but there is an option that, I mean, you can go ahead and do it. The reason I don't do with these soft tissue surgeries is, first of all, the implant that I use are smooth surface at the coronal part. So even if they do get exposed, it is not really, it is cleansable for the patient. A lot of clinicians like to do a surgery during the implant placement. That means they will advance the buccal pad, fat pad, and try to cover that. Or, like I said, the only thing that I did was using PRF and keeping your incision a little more palatal than in the mid crestal would help. And if you're following the Zaga protocol, your implant head is going to come at the crest. So, you usually will not have these kind of issues.
Yeah, thank you. I'm curious, I don't do any of these kind of surgeries. Do you find, given that, as you mentioned, the dimensions, some of these areas like transnasal are very small dimensions, and these are patients generally who've had quite severe atrophy of the bone. Do you find a correlation between them having severe atrophy and having even less dimensions in these air sites, or does it not make a difference? So they could have lots of thick bone in like the transnasal area, but they have severe atrophy of the maxilla, for example. What is your experience?
Usually when I get these patients, there is usually generalized atrophy that I see. Very rarely will I see that there is bone present anywhere. So no, I don't see that there is, at least. So again, where I practice, patients in India usually have a lot of atrophy, and the atrophy sets in very fast. Within a year, the patient becomes extremely atrophic. And the kind of patients that I deal with, I rarely get patients who have got bone. So there is generally generalized atrophy that I see.
Yeah, thanks. And then you showed us some cases with guided surgery. Do you think there's a place for navigation? Because not all areas you can make a guide to access easily. So do you think that there's a place for navigation guided implant placement in some of these areas? And do you think, if so, that will increase acceptance given the fine margins you have?
Dynamic would be great in the sense that the chances of making mistakes are much lesser. And however, as you correctly pointed out, it is relatively newer technology in India. It's not really available. And if it's available, it's quite costly. So we need to wait for a few more years when it becomes a little more affordable for us to go ahead and use our dynamic navigation system.
Okay, and then I have one last question. Given studies by guys like J. Robert Springer and Uli Grunder and all that, speaking about the volume of bone around conventional implants in the alveolar process needing 2 to 4 millimeters for long-term stability, these remote Anchorage implants are virtually the opposite, where you have very little bone around these things. Why do you think, or do you have a reason why those issues are not such issues with these type of implants then, given they're usually full arch and there's limited bone?
So like I told you, I also showed you a case where if you want to follow the conventional method where you want the bone, you want the soft tissue, go ahead and do your extensive grafting. The problem is I would not mind doing that. The problem is acceptability from the patient side, who are not ready to do or not ready to wait. And that is what exactly I showed you. If you do not give that option to the patient of immediate loading, they would go ahead to some other dentist who would do it. And also the implants, and I'm talking about now, this aside, scientifically speaking, these implants, because when I'm talking about remote anchorage, zygomatic implants, pterygoid implants, they are usually having smooth collars, which are not going to be more prone to any kind of peri-implantitis. So should be okay.
Okay. Thank you for your time. It was really a pleasure to listening to your lecture. Thank you to everybody who stayed up. And for us, not as late as for you. We really appreciate it and hope to hear you sometime soon. Thank you, Komal.
Thank you so much for having me. Thank you, everyone. Bye-bye.
Good night, everybody, and thank you.